Hello, everybody. I'm Marie Tolarova. I am pediatrician and medical geneticist. I serve as a president of International Cleft Lip and Palate Foundation. I also founded and presiding a Cleft Prevention International Foundation. I am with Rotaplast International for 30 years. I did over 50 missions all around the world. My daytime job is in academia. I am professor and executive director of Pacific Craniofacial Team and Cleft Prevention Program at the University of the Pacific Arthur Ardugoni School of Dentistry in San Francisco, California. My clinical experience with cleft lip and palate patients with non-syndromic and syndromic ones is based on several thousand of individual children and adults, which I examined, diagnosed, managed their treatment plan, and also included them in research toward understanding etiology and prevention of cleft lip and palate. In my lecture, in 3 parts, I would like to cover most important topics which you need to understand if you are treating patients with cleft lip and palate. In first part, we will cover classification, diagnostics, craniofacial embryology, and prevalence. In second part, we will focus on etiology and heritability, and also on risk of occurrence and recurrence. And finally, in last third part, we will go over the treatment and prevention of cleft lip and palate. So I am sure you are familiar now with classification, diagnostics, craniofacial embryology, and prevalence. So let's move to second part, in which we will cover etiology of cleft lip and palate, heritability, and risk of occurrence and recurrence. Okay, so let's move to one of the most important topics which we will be covering in this lecture. This is etiology or causes of cleft lip and palate, and related to this is heritability. On this slide, you can see two major groups of environmental and genetic factors which are involved in etiology of cleft lip and palate. You can see triangle of genetic factors, which is pink, and then triangle of environmental factors, which is green. Genetic factors are those which are non-modifiable. This is who we are, what we inherited from our father and our mother and from our ancestors, and also some susceptibility genes which we are actually inherited from our ancestors and which make us susceptible to certain conditions, certain diseases, and so sometimes we call them candidate genes. In our case, we will be talking about cleft lip and palate. And one of the most important ones, which are these candidate susceptibility genes for cleft lip and palate, are genes which are linked to folate metabolism. MTHFR, RFC1, and so on, and also genes which are controlling growth. And then we have another triangle, the green triangle, which are environmental or exogenous factors, and these are modifiable. Most of these are actually linked to nutrition and lifestyle, and this is exactly what we are able to modify. So if you look at this chart again, you see that On the left side, we have a very small proportion of these genetic factors, and then we have a large proportion of environmental factors. And then cleft may be present in some of these conditions, which are caused by exogenous, non-genetic factors. And this may be, for example, fetal alcohol syndrome, hydantoin embryopathy, rubella embryopathy. There's also a small proportion of genetic factors which probably are related to severity of these conditions. And then on the right side, you can see large proportion of genetic factors and a small proportion of environmental ones. And these are those conditions which are mostly syndromic clefts, and clefts which are part of the combination of certain characteristics and symptoms which are defining syndrome. We have Apert syndrome, we have Cruzon syndrome, we have Down syndrome, we have many other syndromic ones. And then most of these are actually caused by genetic factors. And then if you look at the middle part of this chart, you can see genetic factors and environmental factors, but you also can appreciate that we have different proportion of each of these factors on the left side and the right side. And this is because not all of us, same type of cleft, and then clefts which are in males and females are caused by exactly the same proportion of genetic and environmental factors. We will talk about it in the following slides. What is the most important is that, in contrary, on right side of this condition, left side on this condition, syndromic cases may be caused by genetic factors only, a little bit may be environmental, and on left side, again, fetal alcohol syndrome will be caused by alcohol ingestion, but a little bit proportion of genetic factors. But in the middle part, when we have what we call non-syndromic cleft lip and palate, and isolated cleft palate, these clefts, non-syndromic, isolated one, need always both of these factors present in order to start cleft. So genetic factors must be there and environmental factors as well. And this is actually, let me jump a little bit forward, and this is actually our prediction and then plan for prevention. We can modify these environmental factors, or we can exclude them. And if we are able to exclude them, genetic factors itself cannot cause clefting. As cleft lip and palate are caused by a combination of genetic and environmental factors, we actually call that multifactorial condition, multifactorial disorders. And collectively, these factors, genetic and environmental, are described as a liability. What is really specific about cleft lip and palate is that you need a certain amount of these factors, combined genetic and environmental, to reach the threshold, to reach the certain amount. Beyond of this one, actually the condition happened. In our case, a cleft lip and palate. So as you can see on this slide, in that triangle, yellow triangle here, you can see increasing number increasing number of combine these genetic and environmental factors, and then they reach the threshold, and this is what we are seeing in population. This is when cleft lip and palate actually appear in newborn, and we seeing this in a proportion of those who are not affected. And then below of that triangle, you see the typical bell curve, and that's again another way of describing that. And then you see again general population of unaffected individual, and these actually need a certain amount of this combination of these genetic environmental factors to to reach the threshold, and beyond the threshold they will be affected. So let's go now back to these triangles, pink for non-modifiable genetic factors, and then green modifiable environmental factors. And we will focus on that middle part when we have multifactorial etiology, which means a combination of genetic and environmental factors. What you can appreciate on this slide are actually pictures of children with cleft lip and palate, and describing also and showing the type of cleft and gender. So what you can see that on the left side we see less severe clefts, unilateral clefts, and on the right side we see more severe clefts, bilateral clefts. And also more towards the left side we see males with clefting, and on the right side we see females with clefting. These four categories means that there are a different proportion of genetic and environmental factors in each of these subcategories. So less proportion are actually in males, less proportion of genetic factors are actually in males, and much larger proportion in each of these two categories of type of cleft are for females. So males with unilateral clefts have a largest proportion of modifiable environmental factors. And then compared to right side, female with bilateral cleft, they have much larger proportion of genetic factors, non-modifiable factors, than any other category. From the point of risk of recurrence, it means that those with higher proportion of non-modifiable genetic factors have higher risk of having a child with cleft, and in respect of prevention, larger window environmental factors which we can modify means that we have better chance for prevention. And this will be unilateral clefts, and specifically when we have proband with male with unilateral cleft. Difficult situation will be in bilateral cleft in females, where we have very big proportion of genetic factors. These patients also have highest risk of having a child with cleft compared to other subcategories. This slide actually documents how we confirm that for threshold model of liability to cleft lip and palate. I described this first in 1984. And you can see this on the slide on the left. And then later we actually confirmed this with other studies which we did after that. So what corresponds to this four threshold model were actually nicely fitting into the bell curve. So the very right end of the bell curve, you see those very rare cases of clefting. And then, as you can see on the table, when you look at the incidence in general population, these are actually females with bilateral cleft. And as I mentioned before, they do have highest risk of recurrence of having a child with cleft. And this is based on our own study when we were actually looking at SIP ships of 3,600 families with non-syndromic cleft lip and palate. And then when we actually applied prevention, again, unfortunately, the very small window which has these modifiable environmental factors in cases of bilateral cleft lip and palate in females didn't allow us really successfully achieved efficacy of prevention of cleft lip and palate, which we used in our protocol, which I will be describing later, with high dose of folic acid and multivitamin periconceptionally. Another good documentation of differences in these four categories is actually value of heritability, as I mentioned in the title of this subcategory. So heritability, it's a lay language would say, what is the proportion of genetic and non-genetic factors? If we have same proportion of genetic and non-genetic factors, then we will have heritability, which is 0.5. If we have complete agreement with the whatever sign which we are studying, we will have, like in monozygotic twins, we will have a heritability which will be 1. Okay, so a higher number, which is toward 1, means that there is a higher proportion of genetic factors. And as you can see on values of heritability on this slide, you can see that the highest heritability was actually found for females with bilateral cleft. And again, this is not hypothetical. These are data and numbers which are based on that large sample of families which we studied. So let's review important point in this category of etiology. Why we need to understand etiology? For better diagnostics, for better treatment plan, for better outcome, and of course for prevention. There are 4 types of congenital anomalies: malformations, deformation, disruption, and dysplasias. Malformations, they have genetic etiology or genetic environmental etiology, or some of them also environmental etiology. In contrary to this, deformation and disruptions do have only environmental etiology. And in dysplasias, we again may have genetic and environmental factors, or only genetics and environmental. Genetic factors in etiology of non-syndromic of cleft lip and palate actually are really very broad. It's about 150 candidate, or we better say susceptibility genes, which were described in relationship to cleft lip and palate, non-syndromic cleft lip and palate. And also they are environmental factors, these modifiable factors in non-syndromic orofacial cleft, which are what we would like to call candidate nutrients, which is lack of folate, lifestyle, smoking, alcohol, anti-epileptic drugs, and others. So if we look at causes of congenital anomalies in etiology, uh, in general, it's about 65% which may have multifactorial etiology, which means environmental and genetics. There will be orofacial cleft, neurotube defects, conotruncal heart defect, and then about 25% will be those only genetics. And this will be syndromes which we know well: Apert syndrome, Cruzon syndrome, chromosomal aberration like Down syndrome, and so on. And then we have small proportion, about 10% of environmental syndromes, which are fetal alcohol syndrome, rubella syndrome, and others. Similar is proportion in etiology of orofacial clefts. About 65% of orofacial clefts are non-syndromic. It means again cleft lip or cleft lip and palate and isolated cleft palate. They actually have the proportion, about 65 of those have proportion genetic and environmental factors. But what is really critical, and what we were showing on this four threshold model of liability which we introduced, is that there is a difference in proportion of genetic and environmental factors for different gender and different type of cleft. Highest proportion of genetic factors have females with bilateral cleft, and the lowest proportion of genetic factors toward to etiology of clefting will have males with unilateral cleft. And again, we call the etiology of cleft lip and palate multifactorial threshold model, multifactorial or threshold model, or MFT model. So it means that we have many genes, which is type of polygenic inheritance, and we also have many environmental factors. We also describe liability, which is the combination of genetic and environmental factors, which are accumulating until they reach the certain threshold, and beyond that threshold, each individual is affected with non-syndromic cleft lip and palate. So let's go review also heritability. As I mentioned, heritability will give us a proportion of genetic and environmental factors, measures how much variation of certain phenotype is contributed by genetics, and varies from 1 to 0, and those which you have close to 0 may have largest proportion of that whatever sign which we are looking at by genetic factors. We will see this is monozygotic twins, and those which will have heritability which is below 0.5 will have higher proportion of environmental factors than genetic one, and 0.5 will be the same proportion. So when we look at cleft lip and palate, non-syndromic cleft lip and palate, again I reminding you that triangle proportion, and in these 4 subgroups we will have males with unilateral cleft with lower proportion, lowest proportion of environmental and genetic factors, will have the smallest proportion of the genetic factors compared to others, 0.64. For females with unilateral non-syndromic cleft lip and palate, we have 0.77. Again, higher proportion of genetic compared to male with unilateral cleft. And then finally with bilateral cleft, we have a highest proportion for females with bilateral cleft, when we have almost 0.9 proportion genetic factors to environmental one. And again, a higher proportion of genetic factors, higher value of H square, which is heritability, means that more heritable genetic factors, genes, will be passed to offspring for mother or father with the similar phenotype. So now, when we understand etiology of non-syndromic cleft lip and palate, we can actually look what is the risk of occurrence that cleft will occur in population, and what is the risk of recurrence that my patient with cleft lip and palate will have a child with clefting as well. So risk of recurrence. Risk of recurrence is actually equal population prevalence. If there is no family history of the same condition in relatives, we are looking at population prevalence or risk of occurrence in population. It will differ in different population. It will be influenced by ethnicity. It will be influenced by sex of the patient and also by type of cleft. And again, we will look at that bell curve and that correspondence which will be with genetic and non-genetic environmental factors, and we will see that prevalence or incidence in general population will be highest in males with unilateral cleft and the lowest in females with bilateral cleft. So what does it mean? That more common type of clefting which we will be seeing are actually unilateral cases and males with unilateral cases. This is again influenced by ethnicity. So in different ethnicities, we may be seeing different proportion that. In this table over here, we can see differences which we are seeing in California population. Very large number of about 2.5 million births which we were studying. So let's recapitulate risk of occurrence. Risk of occurrence means risk of having a child with cleft if there is no relative affected with a cleft, which means no family history of clefting. So risk is the same as population prevalence or in other words, incidence in general population. So if somebody will ask you, what is my risk of having a child with a cleft? Somebody maybe who is participating in our mission there, and your question, fair number one question will be, is anybody in the family affected with a cleft? If nobody in the family is affected with a cleft lip and palate, then risk of occurrence, having a child with cleft, will be the same as population prevalence. So incidence in general population, as I mentioned, is different in different population, in different location, but main influence is actually by ethnicity and also by sex and type of severity of clefting. There is a different different proportion of, again, these categories: males with unilateral, females unilateral, males bilateral, females bilateral, and again, the highest will be for males with unilateral, which we have in Central Europe, one in 1600. Then females with unilateral will be one in 3300. Males with bilateral, one in 5,000. Females with bilateral will be one in 10,000. So any type of cleft with no difference between sexes, with not considering the sex, will be pretty much 1.2 per thousand. Okay, so it's 1 in about 8,033. So again, it varies in a different population, but this is information about European population. So now let's talk about the risk of recurrence. It means there is a family history of the same condition in relatives. Most common for us will be patients affected with non-syndromic cleft lip and palate who is asking what is the risk for her or his children to be born with cleft, or also very often situation where we have parents who are having a child with cleft and they are asking what is the risk for my second child and other children to be affected with clefting as well. So risk of recurrence. So it means again the condition is recurring, returning back to the family, is influenced by relationship to proband, so individual affected with a cleft. So highest will be if the individual for which we are asking about the risk is close relative. It means first degree relatives, siblings and children. So in other words, if a patient with a cleft is asking, what is my risk for having a child with cleft? Is pretty much similar as mother who is asking what is my risk for second child being affected with cleft, and there is an increase 40 times compared to population prevalence. So in compared to somebody who does not have a family history of clefting to somebody who does have first degree relatives, means asking for either a child or siblings, will be 40 times higher. It's influenced by sex, sex of probants, sex of individuals at risk, is influenced by type of cleft, by severity of cleft, and by ethnicity. And again, very important are environmental factors, because that liability is a combination of genetics and non-genetic factors. Those which are modifiable, and this is exactly those environmental factors, nutrition and lifestyle, which they will actually act together with those with predisposition, non-modifiable genetic factors. And the way how we understand this in these days is actually that reaction together, that interplay between environmental and genetic factors actually regulated and directed by epigenetics. And again, risk of recurrence in siblings and children, as you can see on this slide, will be lowest for children or siblings of individual with unilateral cleft who is male, higher for females with unilateral cleft, much higher compared to males with bilateral cleft, and highest for females with bilateral cleft. So let's review risk of recurrence. Risk of recurrence is different from risk of occurrence. It's actually reoccurrence. Very important is positive family history. Different, of course, between a family history for first degree, second degree, and third degree. And on the slide, on the pedigree on the right side, you can see who are first degree relatives, marked in red, who are second degree relatives are marked in green, and third degree relatives marked in blue. And of course, it means that much farther individual affected with clefting in family is from the individual for which we are asking a risk, that risk will be lower. So again, influenced by relationship to probants with clefting. Highest for first-degree relatives, siblings and children, as I mentioned before, 40 times higher compared to population prevalence. We will follow here very closely four threshold model of liability, which is influenced by sex of individual, which lowers risk of recurrence for males with unilateral cleft, and then increasing with females with unilateral cleft, then following by males with bilateral cleft, and then highest one will be for females with bilateral cleft. It's more also influenced by ethnicity. And of course, very important is reaction or interaction between genetic and environmental factors, which is actually epigenetics activity. So there are different thresholds of liability, as we discussed before. Then first-degree relatives in general do have pretty much risk for relatives, which is compared to square root of population incidence. So again, if we consider population incidence 1 in 1,000, then the recurrence risk for first-degree relatives, which means siblings and offsprings, will be 1 in 30 to about 3%. And on the table here, we can again review the proportion which we have in general population prevalence, risk of recurrence in siblings, and heritability, which very, very nicely correspond to four threshold model, which I described decades ago. So we finished part 2, which will actually get us good knowledge about etiology and heritability, and also about risk of occurrence and recurrence. All this, including information which we gain from part 1, are very important for understanding treatment and prevention, which we'll be covering in our last part. So thank you very much for your attention, and get ready for last part of our lecture.